Hi, welcome. I'm Lizbeth Rotruba. I'm AvaSure's Chief Clinical Officer. And thank you for making me laugh, Dana. Help me relax too. I'm excited to be here and share some great best practices that our customers are doing to support the nursing staff at the bedside. And I'm very excited about our first presenter, Aurora Gomez. She's the director of TeleSitter and the float pool at Valley Health System. Hi, Aurora.
Hi.
Welcome. I am so excited about this session because we are starting right out at the beginning on the introduction video I saw. It said, start, scale, succeed. And so Aurora, we're going to start very practical and learn what they have done over the last 4 years because they're at the success point. They've had amazing outcomes there in Nevada. Falls with injury are down 50% since before they started AvaSure. Their utilization of their program is high at 80% of their devices fully used at any given time. And they're projected to save over $1 million this year with falls and sitter cost reductions. So, and this didn't just happen easily. And so Aurora is going to help give you all some practical tips so it doesn't take you 4 years to get there. You can come right out of the gate and apply some of what they've learned. So Aurora, welcome. And can you share with us just a little bit about your program, where you are, how many devices you have, and your role?
Hi, we are Valley Health System here in Las Vegas. We are a part of the, UHS corporation out of King of Prussia. And here in Vegas, we actually have 5 hospitals, acute care hospitals, and 1 new facility, acute hospital to open in the fall of 2024, and 1 consolidated rehab facility. So right now we have 6 facilities that we are doing telesitting. We have a total of 90 cameras, and actually we are getting another 5 more for the rehab facility. The history of this telesitting program, actually this is sponsored by our corporation, the UHS, because the Valley Health System has plenty of falls. We have the highest fall rates in all the system acute facilities in the UHS, corporation. So it was an initiative of the previous corporate CNO, and somebody probably had introduced them to AvaSure technology at the time. And she thought that this would be really beneficial, for fall prevention, because falls has always been a very high nurse indicators, and they are really doing a lot of expenses on this, issue, this challenge. So we did a pilot last October of 2019 on 3 facilities. And actually, it went live on all the 6 facilities in January of 2020. So there's 6 facilities that were, we went through all these strategic planning and coordination with the AvaSure education, all the clinical expertise, because this technology is something new to us. We are so much in like a one-to-one direct patient care. So remote monitoring is something new to the Vegas market. And everybody was really had an eye on this technology. Mm-hmm. So I was given that, that opportunity to really research and actually to implement and learn about AvaSure cameras. So great. Then when we actually, it's a lot of planning. You have to do your research and coordinate with the AvaSure because you gotta do all your policies, procedures, and all that. And also you have to bring them into your to your facilities, and also a lot of IT. I'm not an IT person, I'm a nurse, but I learned the hard way. So that's the key, is really technology, because
Yes.
they're gonna be asking you, about servers, configurations, and all that. But it's easy to learn. But
Great.
with the help of the AvaSure personnel and their experts, their clinicians, we are able to really succeed.
Thanks, Aurora. When we talked about your amazing success, so you said you were chosen, and I didn't realize this, you were chosen because you had the biggest challenge across the health system there in Nevada with high fall rates, and you've done an amazing job decreasing falls and have good buy-in and in optimizing the technology. And when we talked in preparation for today, you said there were two keys to your two major keys. I'm sure it's much more than that to your success. And one was the qualifications and training of the staff. And the second was your leadership buy-in and your executive sponsors at all the chief nurses across those 6 facilities. So let's start with the monitoring staff that you use, and take us back in time and what you tried and maybe what you've learned and what your qualifications are now for monitoring staff.
Yeah, originally they told me, because we have to do all this HR thing about what's the requirement, what's the minimum requirement. So from the initial one, they said it's an entry level personnel staff. And this is like a on-the-job training. So we hired entry-level staff, but within 6 months of hiring, because I had to hire quick, because they wanted to, to initiate it and implement it as soon as we can, as soon as we have the cameras already in place. But that was kind of like very disappointing for me, because instead of decreasing falls, I think, I don't know, maybe now that we are monitoring patients, we see more falls. So I think it's just the qualification that some of the entry level, they are not medically inclined, they don't have medical knowledge. The medical jargons, they don't know. They are communicating with professional nurses. So there is no trust, built within this, within these 2 disciplines. So like the nurses would say, how would they know? They're just teletext. So I kind of like thought about that, get there more of like accountability piece as well as professionalism, that I think the entry level or the qualification, the initial minimum qualification will be certified nurse assistant.
Certified nurse assistant, yes.
Yes. So that's gonna be, oh my God, that's gonna be more of now an expense issue, because from entry level salary, now I'm putting in the CNA salary. But I said it's for patient. I have to do my homework again, do all that data. I mean, like, what's gonna, make this program successful, and also for patient safety. So I redid everything, and I was successful in asking the minimum requirement to be a CNA instead of an entry level. But don't get me wrong, there's still entry level that are like medical background, like EMT, patient caregiver. I still give opportunities to those that are not CNAs.
That's fantastic. So I think that'll be helpful for people who might be in the audience today, who are at the beginning of their journey, trying to decide what the qualifications could be. And as they're making their business case, they can say, well, UHS in Nevada started this way, they didn't get the outcomes, and when they elevated it to a certified nursing assistant, they got better outcomes. And I think another best practice that's related to that we talked about was the communication between the CNAs that were doing the monitoring and the bedside staff. So that was better once they had a little bit more of a healthcare background. And two, you talked about handoff reports, and tell me about that. I think that's a real best practice that you have, the communication between the bedside nurse and your monitoring staff.
Yeah, as we go through the journey before, it was not part of our, because it's something new. I had to start from the scratch. I did not know what works and what didn't work. So I base it on my nursing experience. They should have a bedside shift report. So
Yes.
they did like a ship-to-ship report with the TeleSitter, the incoming and the outgoing, but that still doesn't help. I think they should have like an introduction. So this is the start of their day. They introduce themselves to the nurse who is taking care of the patient. Hi, I'm Aurora. I'm the TeleSitter in charge of your patients, today. And then that's when they have to ask what needs to be watched about their patient. So the nurse feels like there's a second eye on her patients, then they feel more comfortable with the teletech. So they'll have some more of a trust issue, and the communication, like, oh, watch for the IV, watch for, like the oxygen or the restraint, or the patient sitting down. They're not supposed to be sitting at the edge of the bed. So these are the report that, that needs to be, given, at the shift change.
That makes so much sense. So your monitor techs are reporting off to each other at their change of shift. And those of you that have our system know that there's a space in the software for them to keep track of things like they have an IV in their left hand, they have oxygen, or maybe they're elopement risk and it's okay for them to pace around the room, but not out the door. And then they also have the handoff with the bedside nurse. And I witnessed this at another organization, Aurora, where the night shift monitor tech, the TeleSitter tech, had reported to the day shift. This patient didn't sleep all night long, but she does like to sleep with her head of the bed up elevated a little bit. And then later, when that monitor tech on the day shift was communicating with the nurse, they were able to say, she is napping this morning, but that's not that she's more drowsy than she was yesterday. We know from the night shift she didn't sleep all night, and we watched her toss and turn all night. So we're going to let that communication, when they are 24-hour eyes into the room, to give those little tidbits of information to the bedside nurse really helps the nurse plan and assess their patients better and care for their patients better.
Correct.
Yes. Okay. And then is there anything else on that before we move on to your leadership support there about the staff?
No, I think that's very important. Those communication and the
the qualification.
Yeah.
Yes, exactly. So you talked about executive support. It sounded like you had system level support to implement this. And when you did do a proper business case, you got support to elevate the job description. So that's fantastic. Two of our colleagues were out to visit you recently, and they saw for themselves, and I hope I don't embarrass you, but that you have a lot of credibility with your peers. So they saw you interacting with other nursing directors and those that you're serving, because you're at the hub and you are serving the nurses at the 6 different facilities. So tell us a little bit about your relationship and the buy-in from the chief nurses that are at all 6 of the hospitals, and one of them the rehab facility, that are your sort of customers.
Yes. I used to be assistant chief nurse officer. I've been with the system for 24 years.
Okay.
So I know whoever goes in and out, and pretty much I stayed with the system, but on different roles. So, so I know pretty much all the CEOs. You used to be our COOs. So they know me. So I think, as you said, the credibility, integrity, like your work ethics really follows you. So I'm proud of that. So, but then that's why when they appoint me this, I said, oh, this is something new, but I'm always up for challenge. So what I did is like, also my responsiveness, if there's a fall or anything right off the bat, you know, they will text me or they will call
Good.
me, but I'm
Yes.
always available.
Yes.
So they know that they can, rely on me, to investigate and find out and what else, what action plan, I'll be doing, to mitigate that, situation. So I think a lot of, as you said, your responsiveness, I mean, your credibility, it says a lot, for those CEOs and the CNOs. And I think I'm fortunate enough to know them all, and even the ones who are incoming, uh, they know me pretty well. So that's part of, I think, my success.
Yes.
But follow through, always follow through,
Do you have routine meetings, or is there a lot of our hub and spokes like you have a system committee that meets routinely, or do you meet just as needed with those CNOs in clinical leadership at those 6 facilities?
They have a monthly meeting,
Monthly.
the CNOs.
Yes.
So sometimes, at one point, they invited me, so I did. And actually, here is the thing with that. We are trying to serve them, the hospitals. And I've been so busy because I started another program for the system. So now that I have May with me, my plan is really to go to each facility, and maybe attend the fall committee, program, but because they have committee meetings, fall committee meetings, each month. So we are planning on that once she gets settled, and then we can, move forward to that. But the CNO level, they invite me once in a while, because especially if they see, I don't see, a lot of, for example, a certain hospital has decreased utilization, or they have, and they can see the data. If they have decreased utilization, they have increased falls. So you go figure.
I love that. Let's stop and repeat that. So I think I like your relationship, your follow through. You have your own credibility, and that good relationship. There are routine monthly meetings, and they include you on those. But the data, and what I heard you say is really worth repeating. And you're tracking utilization of the devices, which we provide within Orna. And you said they are inversely correlated. If we see decreased utilization at one hospital, you see increased falls. Go figure. I'm going to use your words. Those are Aurora's words. Go figure. So that is really great objective data to bring back and help them pinpoint area and help you pinpoint areas of constant improvement. We did get a few questions that were typed in the chat. One is, and this is just probably a quick and easy question. What is your patient to monitor tech ratio, and does it differ with different types of patients that you're monitoring?
I don't want to put in the policy like a ratio.
You didn't put a ratio in the policy.
I did not put I
yes.
don't want to, because
yes.
staff will go through that policy.
And so will the Joint Commission.
So, right. I mean, safely. No,
yes.
I just say, to monitor safely. I start with 12 patients to safely monitor.
Yes.
12 patients. But in case there is a sick call or they have short staff, they can go up to 16.
Okay. I
think that's safe enough.
Yeah.
And then also acuity of the patients.
Yes.
Because they are busy patients. So they go by that, like in assignment making. In fact, I also have to do like a runner. I have a supervisor. When we did all this, they then never thought that I would need a supervisor. They think I'm just gonna be there consistently. So,
It's a 24/7. Yeah.
yeah. So nobody, because it's something new. You have to have a supervisor who still have to watch the people who's watching the cameras.
Yes.
For accountability.
Yes. And
then
the fact that you're a hub with, I think you said 90 different devices across 6 hospitals makes that a lot more efficient, right? Instead of having, yes. Yeah. Sorry, I interrupted.
Somebody to get a FTE approved.
Yes.
Correct?
Yeah.
So I did that, and then, okay, you have a supervisor, but then they ended up doing lunch breaks.
Sure.
Or 15-minute breaks. On a 12-hour shift, you require 2 15-minute breaks and 1 30-minute lunch break.
Yeah.
So their day is done.
Yes.
You know, so what else can they do? So I again have to ask for a runner, but it's within the census. You know, it's productivity. So I learned that, you know, so as so many patients we're being viewed, for example, 72, or we're at 80%, you know, utilization, you could have a runner.
Yes.
You know, so or else if it's low utilization, the supervisor can do, you know, can do it. And also with May being here as a nurse manager, she could be also a supervisor. So the more leaders, the better, at least. And also when there's a sick call, that supervisor sits, so they don't watch more than 12.
Okay. So what I'm hearing is some flexibility in there, and it's patient-centered. So you're really adjusting to the acuity of the patients that day. AvaSure's best practice policy has a failure protocol based on data. So if there's too many SAT alarms within a short period of time, or the monitoring staff are just way too focused on one particular patient that they can't watch the others, that's how you adjust the ratio, not something set in stone. So that makes a lot of sense. And I just want to wrap it up. We got just a couple minutes left. Do you have a great catch story that you'd like to end your session with?
Yes, this was actually a year ago. One of the patients, they were watching one of the patients on a high flow oxygen, and the patient was kind of like somewhat sedated, restrained, but the patient was waking up, and the patient, you know, untied one of the restraint and removed the oxygen, and the tech actually has to zoom in, and because, you know, and then patient was already blue, but she has to call. We can call the nurse, I mean, start the alarm quickly.
Yes.
And then the nurse was called too. So that we have 2 measures. We have to start the alarm and also call the nurse. You know, just in case. I know some people just pass through that room. You know, they don't know what's going on, but we notify the nurse right away, and they have to call the rapid response on that patient, and the patient survived and went to the ICU setting.
Thank goodness.
And they were thankful for that TeleSitter.
Wow.
We're doing our job. So
thank you, Aurora. I loved ending on that story, and it was great talking to you today. And thanks for getting up kind of early and your time zone and being with us today.
Thank you also. You're welcome.
Well, welcome back to me. I'm back for you. Let's give Aurora a round of applause. Thank you, Lisbeth. That was fantastic. It's so nice to hear how Aurora was able to make changes. As my role as the Director of Clinical Sales, the #1 question I get on a regular basis is who is going to be our virtual telemetry TeleSitter person watching these patients. So it's really nice to hear that from Aurora and her organization that they did identify the most key role to be able to watch those patients.